All right. Good evening, everyone. Thank you for joining us. We'll get started here in just a moment. We'll give it just a few more minutes for everyone to get joined.
So how's your summer going, Mike?
Bonkers.
Bonkers.
Bonk. Yeah, bonkers. Such a benign question, Frank. Um, I
It's
have
super
four.
open-ended.
Yeah. Well, I have four kids.
Yeah.
Um,
Yeah.
and
Did
21,
you,
18, 15, and 13.
you just
Uh,
moved someone off to college last week, right?
yes. So the 21-year-old got married earlier this year, moved to Canada, Northern Alberta,
Oh,
where his
I
wife is
know.
from. And then my
wow.
18-year-old moved to college yesterday or last week.
Wow.
Okay.
Holy cow, man. I mean, they do what they're
Half
supposed to do. We raise them to launch. They're doing it. And you're
half
like,
empty house.
I miss
Yeah.
you people.
Is that Matthew that lives in Canada?
Yeah, he does.
Okay. Okay.
Yeah.
He's been such a delight to speak with.
Oh, that's awesome. Yeah, he
Yeah.
handles all of our marketing. He's doing a fantastic job.
Excellent. Very
Yeah.
cool.
How about you guys?
Wonderful.
I have a
Trish, how's your
baby,
summer?
so I have a baby, so my whole summer has been raising
Oh,
a 1 year old, and then I have a teenager as well that just started high school. So it's been a bonkers summer too.
yeah,
Yeah,
got it.
yeah.
Right
Frank,
on.
did you marry off anybody? Did you have a baby?
Me-
Like, what did you do this
I
summer?
I've had a couple of adventures this summer, mostly
Went to
unplanned.
Spain.
I'm sorry.
I said you just went to Spain.
Yeah, yeah, I that's one of the unplanned things. I actually went to Spain and did something called Camino de Santiago. Not sure if you're familiar with that. It's like a pilgrimage. I believe it's a religious thing. I didn't
Okay.
specifically do it for that, but it was a very interesting
Hmm.
7 day hike for me. It was very
Wow.
cool. Going from town to town and just kind of doing a like a 20-kilometer hike in between. It
Hmm.
was quite, and it was just me. So I got
Wow.
to walk with myself and that was
Hmm.
interesting in itself.
Wow.
I'm
Wow.
able to live with myself. That's a good thing, I guess.
Yeah. Yeah. That's cool, man. Really
Yeah,
cool.
yeah. That was an adventure.
Very cool.
Right on.
Alrighty, we're gonna give it just about a couple more minutes. You'll notice that your camera is off and you are muted. That is correct. Um, there is a nice little view button in the upper right-hand corner I like to select that allows you to do a nice side-by-side of Michael and his PowerPoint. I just think it's a good way to view the webinar today. So go ahead and mess with those settings if you'd like while we give it just a couple more minutes.
Right on. It's
Hmm.
amazing.
I know I wasn't. Matthew had emailed me the other day about I think the CEs for the webinar, which we'll get into in just a moment. And I like had started to reply, and I was like, wait a minute, this isn't Michael, this is Matthew. You know what I mean? Like at
Yep.
first glance, when you're like busy with your
Yep.
day and you're just like replying back to emails, I was like, oh
Yep.
wait, different one.
Yep. Yep.
I love that though.
Hey, while we're waiting just for the last minute or so,
Yep.
I see some familiar faces or faces. I can't see your
Name.
faces. I see some familiar names of friends out there,
Yeah.
but if you guys can tell us where you Trish opened up the chat. So if you can tell us where you're
Yes.
tuning in from, that would be awesome. I'd love to see that.
I do recognize some faces. Dr. Arias, she's in Arizona.
How about where you're tuning
Lenny,
in
we can't
from
complain about heat
and what
when
the
you're
temperature is? Let's see what the temperature is in
Oh,
Fahrenheit
yeah.
where you're from. Yeah, because there's some friends from Arizona and at least one more from Vegas. So I want to see who's winning.
Yeah. There's
nice
a
and toasty, Lenny.
Dr. Slevsky. She's Denver slash New York. I think she lives in both. So that could be interesting.
Mm,
Tampa's warm for sure.
Yeah. Alrighty. Well, while you're doing that, utilize
Go ahead.
that either that chat box or that question and answer box. You can really put them in either or. We'd love to hear where you're from and what the temperature is there. I'm going to get started here while the last few people are joining. Welcome so much to we really appreciate you joining our webinar. Welcome. Thank you for joining us. We do these every month and we're so thankful to have you here with us and spending your evening. This is going to be a really fun webinar with Michael. We're also offering CE credits this evening. Thanks to Awaken to Sleep. We always appreciate that. So stay tuned to the end. I'll put a link in the chat where you can fill out a survey to get your CE credits for those. So like we had mentioned, your camera is off and you're muted for the webinar, but the chat and the question and answer box are always open throughout the webinar. So feel free to drop your questions in there. Michael will keep an eye on that so that we can get those answered if there's anything that you need throughout the webinar. So today's topic is hedging your bets and how DSM practices build lasting revenue through oral appliance therapy, laser therapy, and TMD treatment. So before we get started with the webinar, I'm going to pass it over to Frank for a few of those new faces on there to talk a little bit about True Function, and then we'll get into Michael and the webinar.
Cool. Thank you, Trish, and everyone. In case you don't know, Trish has run these webinars all along for the last few years now, and you do such an amazing job. And your hair always looks wonderful. So keep up the great work. I thank you for that. Mike, again, thank you for joining us and for being a part of this. We value our relationship and we're grateful for your time and sharing your expertise with us. Everyone, I'm Frank, founder of True Function. We've been doing this for quite a while now. We're on year number 27. We started in 1999. And what we specialize on is oral devices. So we make TMD splints. We make oral devices for treatment of sleep apnea. And I think what makes us special is, we do things a little different from the lab perspective. Our goal is to bring value in different ways, such as, the educational component that we're doing here, but also the technical support and expertise that we bring, the great and wonderful people that are our partners, like Awaken to Sleep, and wonderful people that work with us, like Trish and Marco and Eric, bunch of the people that you talk to all the time. So we're blessed to be here with you, and we thank you for joining us and sharing your time. And we look forward to another 27 years. So thank you all and welcome.
Yes, thank you, everyone. And of course, thank you, Michael. We always appreciate, we love seeing you every year. And I'd like to introduce Michael officially now. Michael Cowen is the CEO and founder of Awaken to Sleep. He started his journey in sleep medicine in 2003, performing in-lab sleep studies as a pediatric sleep technician at Loma Linda's Children's Hospital in Southern California. And 5 years later, his training and expertise empowered him to save his infant daughter's life from obstructive sleep apnea, a leading cause of SIDS in infants. And he has deeply scared me into making sure that my child is safe and sound in that area. After recognizing his calling to passionately assist others in helping their patients, Michael's become an expert in the business of sleep medicine, working with physicians, building sleep centers in CPAP technology, and home sleep tests. In 2015, he founded Awaken to Sleep, which empowers growth-minded dental practices to pivot through proven dental sleep medicine and business coaching, turning their 5-year goals into a 2-year reality. So thank you so much for joining us, Michael. I will pass it over to you. I'm going to go off camera, but if you need anything, I'm right here. Okay.
Sounds great. Thank you.
Thank
both
you.
Frank and Trish. You guys are, you're fantastic. You're always gracious hosts, and it's a delight to come on here. So yeah, thank you. All right, everybody that is on here tonight, I've already asked you where you're from and how hot it is. I think my friend Olga in Vegas won at 105. I think she beat out Tucson by 3 degrees. If you would, I'm going to ask you, I prefer, Lord knows we all sit on enough webinars. Yeah. I prefer ones that are interactive. We'll have a little bit of fun tonight, but I want to be helpful to you, which means the more you can interact with me, answer the questions I've got, I will do my absolute best to answer everyone's questions on here. If you could answer me this in the chat, are you currently treating sleep and TMD, and are you using lasers? So oral appliances for sleep apnea, laser treatment for snoring, or anything else, and any type of TMD treatment. If you could just give me a yes, no, or list those things in the chat, it'd be super helpful. I'd love to hear that. So I'll keep going here. We got plenty of content to get through. Trish already referenced this, but my why. This is my beautiful family, my new daughter-in-law. My oldest daughter, Anna, is the one on the furthest right in this picture. That's my beautiful, healthy daughter who's no longer an infant having sleep apnea. If you have kids like Trish does, make sure they're breathing. That's a kind of a no-brainer. We didn't. I mean, I was a sleep tech for 5 years, and Anna started turning blue in our arms. She'd fall asleep and she'd turn blue. It ended up being from her reflux as an infant. We were able to correct the reflux. It automatically corrected her apnea because that was her root cause. That said, if you have small kids, young toddlers, infants, they have sleep issues. If they're, infants wake up all the time, but if they're turning blue, that's a game changer. You got to fix that. If you have any interest in like the clinical information, buy an Owlet sock. They're like a couple $100. It's not cheap, but it's a sock you can put on your infant. I wish we had those back then. Thank God I had the training to know what we were dealing with, even when some of the doctors didn't. We had a fantastic pediatrician. Anyway, that's my story. Treating sleep is crucially important, not just to your practice, but to your patients. So we start with patients first, and then we let the money handle itself in the practice. I'm going to focus most of tonight on the business side of things. I want to make sure that we have a very clear understanding of this. We already hit that, so I'll skip that part. I want to make sure we have a clear understanding of how do we integrate these technologies and treatments into the practice? How are we evaluating which revenue model makes sense for your practice? In network, out of network, are we doing any medical billing? Are we just fee for service? Are we only doing TMD? Are we doing the trifecta of sleep and lasers and TMD? All of this stuff matters. I don't want you to walk out hearing, oh, here's one way to do it. I'd really love to answer your questions if you have them, or at least give you an idea of how wide and how long this runway is for these 3 different types of treatments. I want to formulate a plan. I want to give you at least, I'm not a doctor. I think that was clear in the introduction. I spent more than 2 decades in this space. I'm not you. So I'm not going to try to tell you how to diagnose TMD. I can tell you how you can diagnose OSA. I helped do it as a sleep tech for a long time alongside of sleep physicians. That's not the point tonight, but I would like to help you formulate your workflows so you can identify and triage these cases and know when are we combining treatments, when are we doing it separate. And then finally, I'd love to help you see how you can develop both your financial treatment plan in the case presentation, but also your referral network. So most GPs are going to focus on their first patients, meaning their own. They're already in your practice. They're already in your chair. How do we talk to them? That's fantastic. Also, I want to talk about how do we get physicians to start referring? How do we market to the public? How do we do, which therapies do we market to whom? We're going to try to cover a lot tonight, folks. So I'm going to not hopefully talk too fast, but I am going to try to get through this because I want to make sure we do hit all of these points well. All right. Love that. Your first baby purchase. Good job. No lasers. Okay, cool. I'm going to keep going here. All right. Let's talk about the DSM opportunity. And DSM, dental sleep medicine, I think everybody on this call knows that. We have a massive undiagnosed market, right? 80% of people remain undiagnosed. Most of the patients that you will get from physicians, I shouldn't say most of the patients you'll get from physicians are already screened, tested, diagnosed, treated, and they're coming to you for secondary treatment. So if you look at the patient's life cycle in this movie of sleep apnea, like they're way towards the end of that movie because they're being referred for secondary treatment after failing CPAP. Fantastic. They're highly motivated. They've got all the documentation. All the heavy lifting is done. But we got to find those referral sources. We'll get to that in a minute. Also, you've got snoring patients. Snoring is the #1 symptom related to sleep apnea. If you guys have been to any CE about this topic before, you know that. But did you know that a third to up to 40% of Americans snore? The #1 bed partner complaint, head and shoulders above every other complaint, is snoring. We have a thing called sleep divorce, where people are happily married and they sleep in separate bedrooms because they can't be in the same noise zone as their snoring bed partner. A lot of issues there. Just those two markets, we have a tremendous amount of patients. And that doesn't even include the ones that are hiding in plain sight, sitting in your dental chair, in your hygiene consult, waiting for you to talk to them, right? So we got a lot of opportunities, my point. I want to talk about tonight's webinar. I want to break it down. I try to break it down into buckets so that it's easy for you guys to take the information. And if you're taking notes, great. If you have a note taker, great. I want this to be simple so you can actually take this and do something with it after tonight. You've got more information so you can make an informed decision towards action. The only loss to me is if we learn things and we don't do things. So whatever you do, please give yourself the grace to do more. Even if it means you're going to make mistakes and you got to fix it later, great. Do more good work because these people are in your chair or in your community. They need your help. All right, rant over. I'll come back to the slide. 3 revenue wells that I want to talk about. Oral appliances, medical billing or not, we'll talk about both. Laser therapy, always going to be cash. TMD treatment can be reimbursed. Mostly it's going to be fee for service depending on the treatment that you offer. These hedge your bets, hence the title, because you can have a balance of fee for service, meaning cash-based business and insurance-based revenue. It's going to help your practice remain balanced in the long run. So first revenue well is oral appliance therapy. We're going to identify mild and moderate patients and CPAP intolerant patients as the folks that we're going to get to work with. Can you treat a severe patient with an oral appliance? 100% yes. After they've tried CPAP, please don't try to get your severe patients to try oral appliance first. That's a fool's errand. It's unnecessary. We don't need the headache, and we don't have to force people into our care. Please, mild and moderate, diagnosed, first-line treatment, you can do an oral appliance as per the AASM guidelines. It's the patient's choice. If they're severe, have them go to CPAP. Those are the people that we can serve. Mild and moderate, CPAP intolerant. From a dollar amount, let me be abundantly clear here since we're on a public recorded webinar going out to the masses. I am not trying to set your fees. This is an example on the slide. I'm going to give you ranges right now of what we see. Awaken to Sleep coaches, dental practice owners across the United States. That's our market. What we see across the country is if you bill fee for service, the range for that is typically $2,800 to $4,500 for an oral appliance for treating sleep apnea. You can bill higher than that, some do. But if you're looking at the bell curve, most people are going to sit within $2,800 to $4,500 as their full case fee. That includes the initial impressions, the delivery, all of the adjustments, and follow-up testing like titration testing. So that's an all-inclusive case fee. What we see on the medical insurance side is anywhere from $5,500 to $7,800. And typically, like, that is actually growing higher. That sounds like a huge range. The top end of that range is actually significantly higher than that 78. But again, bell curve, outliers aside, $2,800 to $4,500 fee for service, $5,500 to $7,800 for a case fee on the medical billing side. Also, let me be clear, you don't have 2 fee schedules. You only have 1 fee schedule. 1 fee schedule for each code that you do in the practice. If you bill medical insurance, you can't have a separate fee schedule. That's a different webinar altogether, but we'll keep going. When you are billing medical insurance, again, this is oral appliances. We're going to focus on that because we know that there's medical insurance coverage here. How do we get paid for that? Well, we need to have 5 things. 5 required documents every single case, or you're not going to get paid. What do we need? Pre and post chart. Well, first off, we need to know who the patient is. Let's get their contact information. We call it patient demographics in the medical insurance world. So that's usually like a 2-page document that's every contact info, their emergency contact, blah, 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 and their insurance information. We should get that from the physician's office when they refer patients over. Second, we need pre and post test chart notes. Why do we need that? We need to demonstrate to the insurance company that a physician has initiated the care for this patient, i.e., they identified snoring, fatigue, whatever sleep symptoms, and then they sent the patient for a sleep test. The insurance is playing dirty pool here. They are going to disallow payment for your treatment if they can identify that you as the dentist initiated the sleep test. That's terrible. If they don't want to pay for the test, that's one thing. But to not pay for a test, to not pay for treatment for a test that was rendered properly, diagnosed medically, that to me is dirty pool. But you know what? That's their guidelines. So let's make sure that we have a physician initiating care by ordering the sleep test. So that's the pre-test chart notes. The post-test notes are going to say, this patient has diagnosed apnea based on this test, and this is my recommendation for them. I'm prescribing an oral appliance. Pre and post-test chart notes, we need a sleep study, that's the test, with a diagnosis of mild, moderate, or severe. If they're severe, again, we need them to try CPAP first, and we need that test to be recent. If it's Medicare, you have to have that test done by a different provider. You cannot do that test, even if it's ordered by an MD. You can't touch the test and the treatment. So Medicare, no testing. All other PPOs, you can render the test, but it has to be diagnosed and done within 12 months for Medicare and recent for PPOs. If you just say 12 months for all people between the date of the test and the date of delivery of your appliance, you're in a good window. So patient data, pre and post-test chart notes, a sleep study with the proper diagnosis within the proper timeline. And the last thing is you need the physician's prescription for oral appliance therapy. If you have those 5, you have what you need to move forward with care in medical billing. When we are talking about fee schedules, remember I said I can't set your fees. That's not my intention. Here's an example. Here's some ranges. Here's a much better tool. Go to fairhealthconsumer.org and pull up your zip code, your codes for billing medical insurance, and see what the ranges are. You can actually use this tool for both dental and medical codes. The entire CPT billing code list for all codes in medicine and every D code that exists in dentistry is on this site. And it's a consumer-facing site. So the goal is to inform consumers what is the in and out of network dollar amount that is currently being billed for these services that you should expect to see. Fantastic information for you to find out. Are your dental codes on point if you're doing general dentistry? Are your sleep apnea codes on point based on what the ranges are in your market? So use this tool to find that out. All right, let's keep going here. Let's talk about our second bucket. Second bucket is laser treatment, laser therapy for snoring. This is 100% unequivocally fee-for-service. You are not going to get your laser treatment covered by insurance. That's okay. We have significant high margins in this, low time that's required, and we have a piece of incredible equipment that we can use multifaceted in the practice. But here's the thing. Let me explain how this would work. You have, again, a range, let's call it $400 to $800 per session that you would charge for a laser treatment. You're going to address the soft palate for snoring. Let's say that patient says yes. You know, with, let's say, the Quiet Night by Decca as an example of a laser that's in the market, if you use that piece of equipment, you would have a 10-minute chair time with the patient, roughly 5 minutes for the procedure. 95% of patients do not require any numbing at all. So you have 10 minutes of chair time with the patient. You're going to charge between $400 to $800 per session. We know that those patients need roughly 3 sessions, 1 month apart. So you have 3 office visits. You'll probably book that chair for 30 minutes, even though you only need 10. And you're going to sell that in an $1,800 package for the laser therapy for snoring. 3 treatments, 1 month apart, 10 minutes of chair time each. That's a pretty solid investment on your chair time, yeah? Even if we increased it to 30 minutes, because that's when you block the chair, so you're going to turn the room and all of that, that's an hour and a half of chair time, and you're generating $1,800. We're pretty okay with that. And very little of that time is actual doctor time. You do have to be a licensed dentist to perform the laser treatment, yada, yada. You can talk about that from talk about that with your laser company. If you did 1.5 cases at this rate, 1.5, there are no half patients, but 18 cases in a year, you're going to pay this laser off. Okay, so the ROI is there on a piece of equipment that can do the work. Remember, 1/3 to 40% of the American population snores. It's the #1 bed partner complaint. Talked about obstructive sleep apnea. Now we talked about lasers. Let's keep going. Number 3, TMD treatment. How many of you are doing TMD treatment on here? I asked for that already in the chat. If you can throw that in here, if anybody's doing TMD treatment, I'd love to know if you are doing orthotics, if you're doing Botox, if you're doing PRF, trigger point injections, anything else. I just listed several. That's not the comprehensive list. Let me get back into this, into the revenue well that sits here. One, if you're treating TMD, we really, really, really need a cone beam. If you don't own one, refer out to somebody that has one. But we really need to understand, one, are we dealing with a skeletal muscular issue? Are we dealing with a muscular issue, meaning pain? Oh, I have TMD. Where does it hurt? Here, here. Okay, these are muscles. The joint is here. Again, guys, I'm not a doctor. I'm dumbing this down big time. What I'm saying is, if you're treating pain, where is the pain and what's the source of the pain? If we're bruxing and grinding, Botox and a night guard might actually fix this. But if we don't know if they have obstructive sleep apnea, i.e. they haven't done a test, then we actually don't know if our single arch flat plane splint is going to create worse apnea, because that's what they found in the Houston Sleep Consortium back in 2013. That's a study you guys can pull up. So we need to make sure, are we treating the right thing and how are we treating it? If you're dealing with PRF, platelet-rich fibrin injections into the actual joint, you're taking the patient's actual blood in office, you're spitting it out in a centrifuge, you're removing the platelets and you're putting it back into the body. So you're helping the body heal itself. You would never do that if you don't have degenerative joint disease diagnosed from a cone beam. So again, going back to diagnostics, we can't treat sleep apnea without a sleep test. We want to have a cone beam if you're treating TMD. Let's know what we're treating. Second, if you're treating TMD or you're thinking about doing this, this is a massive lead magnet. You guys, of all of you that are in general dentistry, how many of your colleagues want to deal with the crazy chronic pain TMD patients? Very few, if any. You probably count them on one hand in your market. If you're treating these folks, they desperately need your help. And there are very, very, very few people in your market that want to actually compete with you. So one of the best places, I'm getting ahead of myself, but one of the best places to find these types of patients is from your actual dental colleagues who don't want to treat them. As long as you promise not to steal their general dentistry, which we'll get to in a minute. Are you operating as a specialist and you're getting GP referrals? Fantastic. Treat them like a specialist, refer them back once you're done. But this is a massive referral magnet. Also, people that are in chronic pain are very motivated to get out of it, because as human beings, we hate being in pain. So we need that, and there's plenty of treatment to do there. Depending on what the patient has clinically, that opens up the different buckets of treatment, as I started mentioning a minute ago. The last thing, if you market for TMD patients, you are automatically going to find sleep apnea cases. If you market to sleep apnea or for sleep apnea cases to your physician colleagues, you're going to find some TMD cases. But some of the biggest resistance I've ever heard from the DSM community is, hey, everybody says that my oral appliance causes TMD, and that's garbage. I've been doing it 15 years, and I've had 2 cases in 15 years, and they were skeletal muscular. They were not true TMD cases. Great, I agree. Oral appliances are actually taking pressure off of the joint. They're relieving the joint pressure, and you're addressing the main cause of their stress, which is oxidative stress from the airway. Great. But there are humongous overlaps in the TMD population that does exist and the airway compromised patients. Those are very overlapping. So if you're marketing to TMD, you're automatically going to find sleep cases. Make sure you are testing for that or referring out for that testing, whatever your workflow ends up being. Huge overlap doesn't mean you're causing it. It means they coexist. All right, let's keep going. How do we bundle these? This is a big conversation I have with clients on a frequent basis. Let's assume that you are in a spot clinically where you have the clinical knowledge to treat oral sleep apnea with oral appliances. You have a laser like the Quiet Night, and you also have the clinical capacity to treat TMD. You know how to treat with orthotics, Botox, PRF. Let's just use those as the 3 examples. Well, how do we put those together? Are these 3 different types of patients? You just said, Mike, that they're overlapping. Well, what the heck? How do I treat a sleep apnea case and a TMD case? How do I quote that? I'm glad you asked. First thing, we have to assess people, obviously. Clinical assessment, you're going to take their health history. You're going to take their primary symptoms. Please, please, please take their chief complaint. Why are you here? Why are we having this conversation? When you ask that question in plain English, don't ask them what their chief complaint is. They don't understand that. That's medical terminology. Hey, why are you sitting in the chair today? What is the number one thing that's causing you pain or causing an issue for you? If you could have this, whatever, if you could have something fixed, what is that thing right now? Oh, well, my wife keeps telling me that I sleep terrible. She sleeps terrible and it's all my fault. Hey, does that sound like a marriage counseling issue? No, automatically you're like, oh, you don't have jaw pain, you have side pain because you keep getting an elbow in your side because you're snoring. You have an airway condition. Well, that guy doesn't think he has an airway condition. He thinks he has a marriage problem. And he's here reluctantly, right? Like, let's deal with the real person. So assessment, I'm kind of joking, but kind of not. Please, please don't skip the health history and the real conversation with patients. They are telling you what matters most to them and the path to get them to say yes to treatment. Okay, so the assessment comes first. Do they have obstructive sleep apnea? Are they snoring? Do they have pain symptoms, joint issues, skeletal muscular issues? Second, now we talk about how they can save if they bundle treatments together. Let's assume that we're dealing with a obstructive sleep apnea patient. They've been diagnosed, they've been referred in. We're going to get their insurance to cover a portion of this appliance. Fantastic. They also have their primary complaint that I just said is snoring. They were referred as a CPAP intolerant patient, but their primary complaint is snoring. So what did I just say? The primary complaint is the path to get them to yes. Okay, well, they're here for an oral appliance. They need an oral appliance. They're a moderate sleep apneic at an AHI of 28. It means 28 times an hour they stop breathing. Oxygen drops, airway collapses, has to open up with muscles in the throat, so their brain has to wake up. So roughly every 30 seconds, twice a minute, or I'm sorry, once every 2 minutes, my math was off. Once every 2 minutes at an AHI of 28, they're waking up to start breathing again so they can sustain life. That sucks. They sleep terrible and they feel terrible, whether they know it or not. Okay, but their chief complaint was snoring. So if we bundle this, let's say we have to address the appliance because that's what they need, that's what they're referred for. And patients like them that have snoring as their primary complaint, there's actually soft tissue in the back of the airway that we are trying to move the tongue out of the way to get it out of the way, open up your airway and posture it properly. So we are supporting your jaw at night when your muscles won't. Fantastic. Many patients in similar cases to you have seen dramatic improvement in the snoring by combining laser therapy with the snoring. Oh, normally, that's $1,800 for 3 sessions. If we do that together with your treatment, we can start that today. And we also offer a $400 discount. Now, I just rolled that off the tip of my tongue because I talk about this all the time. You're like, oh, that sounds gross, Mike. That feels like you're selling me a car that I don't need. Okay, great, change it. But if you educate up front, you're not making excuses after the fact. Same information, different place in the conversation. If you tell people, hey, here's an oral appliance, here's your copay, your insurance will cover the rest, great, let's go. And then you do the appliance, you scan it, deliver it, you adjust it, you titrate them to their maximum medical improvement position, and they still have snoring. What are they going to tell you? Your mouthpiece doesn't work, doc. I came in here to have you fix my snoring and it's not working. And you're like, wait, I just did the test and your AHI is within normal limits, meaning you don't have apnea. Your doctor referred you for apnea. He's like, no, I wanted you to fix my snoring. Remember, he thinks he has a snoring problem, not an airway problem. So again, your therapy can be working, but if it's not addressing their chief complaint and you offer laser therapy at the end when they are complaining that your treatment didn't work, it looks like a defense mechanism. It looks like an excuse. So if we actually position this up front and say, hey, many patients in your similar situation that have snoring as their primary concern, and they have an airway disorder, they have an airway collapse, when we combine these treatments together, we actually see fantastic results. Here's what your option is. You could do this up front. It's going to save you $400. You could do it at the end. We could decide later if you want to do that or not. No problem. It's totally up to you. How would you like to proceed? So when you get to that same exact clinical spot of resolving their apnea, not their snoring, and they're frustrated, now they're going to say, oh, well, I guess I probably should have done that laser thing a while ago. That's okay. We can still do it now. Would you like to do it now? Sure. Let's get it done today. Either way, you have great margins on the work that you do. You clearly communicate to patients ahead of time, and you're not trying to sell them anything. You're offering them treatment. So we can see how bundling things in a way that helps them where they're at. That's the main thing here. We're helping them where they're at. So we have to understand that. But when we do, it's a tremendous value to that actual person. Lastly, if we do this well, we offer them the care that they need. We are not pushy. We're not salesy. We're not all of those yucky things that you guys feel when we talk about money and business. I don't want you to feel that, and I don't want you to project that. If we help people understand what they need, how we can help fix their main thing, and move them forward, we're going to retain long-term patients. Now, if you're getting referrals from dentists for TMD, that was the example earlier, do not steal those patients because your referral sources are gone. That's like an orthodontist or that's a periodontist that you refer to and they keep your patients for hygiene. Like you're never referring to that periodontist again. Like don't do that. Got it. Don't be that doctor. But if you're marketing to the public, you're not getting referrals from other people, and you want your general practice to grow. So this is an actual lead magnet for your practice. We're marketing to the general public, bringing these people in, market for snoring and say, hey, we got to address your snoring. Well, we need to make sure that you don't have an airway issue because those are related. We're going to get you tested. And if that test comes back negative, do the snoring treatment. And by the way, we can do the snoring treatments 3 months, 3 visits, 1 month apart. And you know what? At that last one, we do a free cleaning at the same time. Book it in your hygiene chair because you've already got well enough production for that hour. Get a cleaning in, even if you had to do it for free, and have them schedule and appoint chairside like they're a normal patient. Make things easy. Sticky means it's easier to stay in the practice than it is to leave. That's how we make stuff sticky. All right, I'm gonna keep going. How do we screen these folks? I promise, like we need to have some clinical workflow. I'm not gonna teach you how to diagnose stuff, but let's just talk big picture. If you have someone that has snoring and they have jaw pain symptoms, we have a concurrent pathway, right? We need to address, are they snoring? Do they have obstructive sleep apnea? No apnea, but they snore, and they have TMD, actual joint disorder. Got it. Well, we've got a laser option and then our TMD protocol. If we have a CPAP intolerant patient with an OSA diagnosis, do they have a snoring complaint or not? We just went through that example. Are they just, I don't snore at all. I make zero noise. I have no complaints. Or I live alone and I don't care if I snore. Got it. Why would we address snoring with that patient? We wouldn't, right? Diagnosed sleep apnea, we now know it points to an oral appliance. So if we're combining things, we know what this looks like. Last thing, just as a footnote, Epworth Sleepiness Scale is a fatigue or daytime tiredness scale that is used by all insurance companies. Make sure you have a score greater than 10. So it's 11 or higher. You can't fake that. You need to ask the patient the questions, or they fill it out on their own with their own hand. But if they don't score an 11 or higher, they do not have documented tiredness, which is crazy. But just make sure if they do have tiredness, they're filling it out properly. So as we screen these folks, it helps us to understand what are we screening for, what clinical context are they presenting in. Then it helps us understand what clinical treatments are we selecting as options to offer care. Then we move to triage and figure out, have they been tested with an oral appliance? Do they have jaw joint pain, actual joint pain? Have they had a cone beam? Do we have a diagnosis of degenerative joint disease or not? All of that. So this is part of our screening, treatment selection, and triage process. Okay. These things can go together, but we need to know, one, we always work from clinical to offering treatment. One of the things that I recommend in phone scripts for your front office, if you have patients calling saying, just tell me how much that is. Well, first off, you get one deflection. This is a deviation from my slides, but I'm going to go with it for a second. Somebody needs to hear this tonight. If you're marketing to the patients, to the public, and they call in and they ask you, hey, how much is your, I called in online, I found you, I Googled you, I used ChatGPT and it found you. Great. How much is this? Well, your front office has one opportunity to deflect before they lose trust. So your automatic answer should not be, oh, it's $3,500. Click. You've had zero opportunity to build value. Okay. So their front office script should be something to the effect of, oh, I would love to give you an answer to that. We never recommend doctor never recommends treatment, and we never offer treatment to patients that we don't know if they need it. So obstructive sleep apnea, there are different types of sleep apnea, different severity levels, and lots of different appliances that fit different mouths and different diagnoses. Have you had a sleep test? Yeah, I have had a sleep test. I have apnea. Just give me the ballpark. If you deflect this time, you lost them because you're now losing trust. You're trying to avoid something and they don't trust you any longer. So if they push that, then give them the answer. We have options in the practice as low as, and it has a number. It could be a snore guard. It could be your temporary sleep appliance for $300. It could be your lowest payment option that goes 5 years out for an appliance. It doesn't matter. It's a real answer for patients that have certain things in your practice related to what the patient is asking. That's your answer. So there's your phone script. Sorry, that's a rabbit hole. Hopefully somebody needed to hear that. Let's get back to the slides so we get through our stuff tonight. When you are presenting the case, I want to make sure this comes across really clear. You will sell more cases. Pardon me. I know you hate the sell word. It's a 4-letter word. You will help more patients in their treatment, accepting treatment, if you sell the case on its merit and not its insurance coverage. You guys know how to do this. Guys and gals, you know how to do this in your practice already. In a general dentistry practice, even if you're in network, out of network doesn't matter. You know that dental insurance is a coupon. It's not actual insurance coverage to cover the things that they need. It's a coupon towards the services that you offer up to a certain maximum. It is the polar opposite of medical insurance, but it doesn't matter. It's a coupon. So if we sell cases based on what's covered, you're going to do that crown this year and tell them to wait on the next crown for 4.5 months until their insurance covers the next one. We need to sell the case on its merit. If they're having obstructive sleep apnea, that's a different sales pitch, a different clinical conversation, clinical education for the patient than if you have a TMD pain patient. Does that pain patient want to wait 4.5 months to hopefully get their next set of Botox covered because the last one helped for like 2 weeks and then it didn't work after that? No, they want to get out of pain now. If the patient actually understands what we understand about choking in your sleep, waking up in order to sustain your own life, and this keeps getting worse and worse, and this is what it's doing to your body, does that patient actually want to live like that? Most don't. But they don't know their clinical options. They don't know how easily accessible this is. Insurance coverage, maybe. Payment options, unequivocally. Have third-party financing in your practice, please, because it helps people afford the care that they need. Give them options. Make it easy for them. We want to give them the right promises. Don't overpromise and tell them that you'll take you'll completely eliminate their snoring. I had one client that said, "Oh, I'll take you from a chainsaw to a kitten. I can't promise you silence, but I'll get you a purring kitten." Whatever. Don't make promises you can't keep, but please, please communicate value in the case on its own merit. They're here for a reason. Give them straight answers, have clear financial treatment options, have financing options to make it affordable, and help them move forward because the therapy that you're offering, the treatment that you're offering, is directly aligned with the problem they're trying to fix. That's a key point in this conversation. So we want to do that. All right, I promised help on medical billing. This is not a medical billing webinar, but I'm going to go quick. I already talked about the 5 key documents, so you know what those are. In order to do anything in medical billing, we have to have SOAP note coverage. End of story. If you don't have a SOAP note, SOAP is Subjective Objective Assessment and Plan, SOAP. It's an acronym. That's a format for medical notes. If you don't have a SOAP note for something that has occurred, it does not exist in medicine. That's it. Very simple. You go to a physician, you see that physician for 2 minutes in urgent care. Some medical assistant took your vitals. The physician saw you for 2 minutes. They prescribed Augmentin for your 4th ear infection this month. Okay, great. That's like a 10-page SOAP note because their software automatically populates that. Yeah, medical billing is important. If it doesn't have a note, it didn't exist. It didn't happen. That's how medicine works. Diagnosis codes are another thing. If you're not familiar with medical billing, it has 2 separate sets of codes. Because in medicine, physicians by and large get paid to think, not do. In dentistry, you get paid to do. There are no there are no codes where you get paid to diagnose something. You diagnose it as the doctor, and then you get paid to do it because you intervene with treatment. Only surgeons and pharmacists are the ones putting their actual hands on patients to physically help them. Most are thinking, and then they prescribe their physical therapy that puts their hands on them, or pharmacy medication from the pharmacist. So in medicine, you have CPT codes, procedural codes that are your billing codes of what you've done. And then you have ICD-10 diagnosis codes for why you did that. Crucially important. You have to have all of that. And then you have to be in compliance with your state guidelines and your billing guidelines. Every single payer in your market has their documented in black and white written guidelines. Please make sure you know what those are. There are some rare cases where the medical insurance company requires a 2-week CPAP trial for mild sleep apnea. Even though that's not part of the American Academy of Sleep Medicine, it doesn't matter. That's the payer guideline. So you have to know clinical guidelines are what manage your license and the physician licenses. Payer guidelines will trump that if they require something extra because they can say, "Oh, well, you didn't do the extra, so I'm not going to pay you." That's their whole game. They make money when you don't. So let's understand what that is and make sure we handle it. Like I mentioned, here's the SOAP note format. If it's not documented in a SOAP note, it did not exist. If you bill something and you don't have notes for it, you're creating an audit risk, and frankly, you're just asking to have a recoupment, which means they ask for the money back with interest. Please don't do that. Make sure you have your notes in line. Make sure you're getting notes from the physicians when they're referring to you. We already covered medical and dental insurance and the differences there. This is very, very important. I mentioned this a little bit ago, but I want to say it again. When you are dealing with obstructive sleep apnea in the medical realm and you are billing medical insurance, so those two go together, your clinical requirement in order to treat someone with obstructive sleep apnea is that they have had a test and they are diagnosed by a physician, not yourself. You can't practice medicine without a license. So a physician has diagnosed the patient with obstructive sleep apnea and recommended an oral appliance as a proper treatment. That's the only thing you clinically need in order to treat that patient and have them pay you cash. But if you need to bill medical insurance, you need those 5 documents. The physician has to initiate the care, meaning they initiate the testing. And please don't miss this. Medicare, if you are billing Medicare, you have to have a third party proctor the test. You cannot touch it. Please don't. If you do, every single one of those claims will get recouped by Medicare, and that is a painful process. Don't do it. So, cash patients, you can do the test, get a diagnosis from the sleep physician. Medical insurance patients, PPO commercial, you have to have the physician order the test. You can render the test if you have that equipment. Sleep physician diagnoses, the physician then orders the oral appliance. With Medicare, it's completely hands-off. Someone else, physicians, triage the entire patient, get them tested elsewhere, then you can do the treatment yourself. All right. I just want to check and see if we had questions. We don't so far. If you have questions, pop them in the Q&A. I want to make sure we get to them tonight. Oh, this one, I'm so sorry. Coming back to the slides. Timeline for testing. You can have sleep centers locally are typically going to be anywhere from 2 to 8 months booked out. The demand is huge. Sleep centers are absolutely not going out of business. The attrition for that has already happened. That whole economy has now settled predominantly. There are very few sleep centers out there, and they have high demand and they're months booked out. If you want to order a home sleep test, oftentimes those are months, but not as long as the in-lab test. The in-lab sleep centers will often do those too. You work with a third-party company that ships tests, you can get them within a week to a month delivered to your patient. So there's some great ones out there. Sleeptest.com is one of them that's known in our space. They do great work. Make sure that it is fully compliant and they are doing the medical guidelines. Diagnosis, physician signature, pre and post chart notes. I cannot say that enough. You guys are going to be like, what did he say? Pre and post chart notes. All right, let's shift gears to building a referral network. Who are you talking to? Well, for sleep apnea cases, you're talking to your ENTs, your pulmonologists, cardiologists, neurologists. What about your testosterone clinics, your bioidentical hormone replacement clinics? What about your chiropractors that are DOT examiners in your market? Do you know that a lot of chiropractors are actual medical examiners for the Department of Transportation? So when truckers have to get their annual exam, many of them, I won't say most, a lot of them, and most in some markets, are going to a chiropractor. And that chiropractor has full medical licensure to order any test. If they screen high risk for obstructive sleep apnea, they have 90 days to get tested and 90 days to get treated and demonstrate compliance with treatment in order to keep their commercial driver's license, meaning their job. Yeah, there's a lot of referral sources. That's just for sleep apnea. If you move on to TMD, we've got dentists. If you're doing airway and laser treatment, we've got tongue tie, frenectomies that you can do. Now we're talking about lactation consultants, all kinds of stuff. Myofunctional therapists. The referral sources are endless. If you are going to talk to a physician, this is true with a dentist, but more in the physician realm, you need to ask 2 questions. 1, what kind of specialty are they? Are they a good fit? And number 2, you're also going to want to ask, are they an employee or are they an owner of their practice? If they're an employee, which is roughly 70 to 80% of physicians today, that's what corporate medicine is. They absolutely do not want your referrals because you're making their life harder and you're making them work harder. They're employees. Treat them like that. Make their life simple. It's easy to refer to me. Here's how we take care of people. Here's how we can work together. Simple. If they're an owner of their practice, concierge physician practice, they want your patient referrals. So talk about how you guys can refer to each other and help each other. Okay. Keep going. The outreach framework. This is important. That's a fancy way of saying, what's your elevator pitch? That's the last line on the bottom here is actually what I'm trying to get at. If someone asks you in the elevator on your way to a physician office, your staff member, your sleep champion that goes out to see doctors, anybody, who are you? What are you looking for? And how do you help? I'm Dr. Martin. I treat patients that can't tolerate their CPAP with mouthpieces to help them sleep better at night. I help patients with obstructive sleep apnea as secondary treatment with an oral appliance. Great. Who are you? What are you looking for? How can you help them? Be able to answer those questions. That's your 30-second pitch, if you want to call it that, or explanation of why you're standing in their office. Your referral packet or folders, depending on how nice or not you want to go. Here's the basics that you need. Maybe it's nice and fluffy and you've got all of this. It looks incredible. Great. Cool. I would recommend that. But if you don't, you can buy folders at Staples and put a little sticker on them. That's going to suffice. At the end of the day, you need a bio letter of who you are and what your credentials are. That's what goes in here. Second, you need a sheet that says, we work with all major insurances if you do. And here's the logos of all those insurances on the sheet. It's not complicated. And you need prescription forms. Tablets are expensive. You can go with those or have one sample that's filled out and then 5 blank ones. Put a business card in there and go take that to offices. Drop it off at the offices, talk to the referral coordinator. You're trying to get the word out. This is how people send patients to you. If they don't have this form, they have no idea how to send you patients. So make sure they have these forms. Print out a bunch, get your folders together, have a box of your trunk stock or whatever you call it, like to put these in your trunk and have them ready when you go out. Again, doctors, this is not your primary job. If you're going to go roll this because you're starting to scratch practice, you got a great personality, you want to meet people, fantastic. Buy a plastic crate at Staples with the hanging file folders and create your trunk stock, which is 50 to 100 folders. Stick them in there, have them at the ready, go drop them off when you feel like it. That's awesome. But this is a basic footprint of what you need in that folder to get it out there. When you follow up, here's a cool strategy. Follow up. Drop off an article, drop off a sleep test report, drop off your last in color printed clinical note from a patient. Anything. There might be an update where United Healthcare last year said, hey, we're not going to pay for Inspire surgery for ENTs until those patients try an oral appliance first. Great. Print that thing out and drop that off with a handwritten sticky note that says it's from me to the doctor. You're finding any reason you possibly can that's legitimate to follow up because FaceTime matters. It absolutely matters. All right, when you're building your referral network, we want to keep doing that. Why? Because it builds consistent referral streams to your practice. It's building the revenue in your practice. It gives you diversification. That matters, you guys. The whole content tonight was how do you hedge your bets? How do you have fee for service and medical insurance payments? How do you do multiple different treatments to hedge the fact that you're in dental insurance, you're in an in-network office, and you can't raise the ceiling on your rates that have been stuck with Delta from like the 60s. This sucks. How do you fix that? Well, if you can't change the face of your dental practice, you can add procedures like this to add incredible value, not just for your practice, but for the patients in their lives. Huge. That's why we're all here tonight anyway. All right, we already talked about stickiness. The cleaning bundle is a big one. Add your next cleaning free of charge when you deliver an oral appliance for sleep apnea, if you're trying to make them sticky to your general practice. Appliance maintenance, have them bring it in when they come in for their hygiene checks. If you're doing your snoring treatment with the laser, make sure that last one comes with the cleaning, that kind of stuff. All right. Revenue. We've been talking about growing the business all night long, and I didn't talk at all about revenue other than general fee schedules. So here it is. If you charge $3,500 for an oral appliance, the $1,800 package for the lasers, and your TMD case is somewhere between $3,500 and $5,500. That ranges a lot. That's not the low, that's not the high, but that's the middle. If you did 2 cases a month for each of these, in a 12-month period, you're making over $250,000. If you do 5 a month in each category, that's not a little bit. That's heavy lifting. That's deliberate action over time. But if you did 5 TMD, 5 laser snoring, and 5 OSA appliances, you're at well over $500,000 a year. That's fantastic. That's talking about treating 15 patients a month for over $500,000 a year. In your dental practice right now, do the math. Are you doing 30 patients a month and making over $1 million a year? Probably not. I'm not going to say probably. You're unequivocally not unless you're in a full mouth rehab office. You're not doing that. So this is awesome. This is fantastic. And it's easy to do this work when you have the clinical knowledge, you have the workflows down, and you have your team equipped. It's hard work, but it's rather simple to get there. It's a very linear process, and you absolutely can do it. I encourage you guys, as you're doing this, please do that. We do coaching. I already talked about that. I'm going to skip this part. We have an event that we are putting on next month. Our room block has 4 rooms left. That's not like fake scarcity. We literally have 4 open rooms left on our room block. It's in San Diego. It's September 18th and 19th. If you guys want to come, please use the True Function discount code because it gets you $250 off your doctor ticket. It's the business of DSM, TMD, and airway. So if you liked tonight, you'll love the course. If you hated tonight, I'm only one of the speakers. I'm sorry if my voice was nails on a chalkboard. I hope it wasn't. If you were just here for the CEs, Trish already put that in the chat, so you can get that. Yeah, Trish, I didn't see any questions. Do we have any questions? I know we're like 1 minute over. I'm so sorry.
No, you're good. You're good. It doesn't look like we have any questions at this time. I have a few more things to say so I can kind of finish up the webinar. Well, if you have any last minute questions, we'll be on here for just a couple more minutes. If you're good with that on time, Michael.
Please.
Put your questions, any last minute things there in the chat or the question and answer box, and we'll get to those before we jump off. Thank you, everyone, of course, for joining us this evening. We really enjoy you spending your evening with us, and we're thankful that you take the time to do so. As you know, we do these webinars monthly, so if there's any topics you ever want us to cover in more depth, feel free to put those in the question and answer box or the chat box, and we'll take that into consideration as we plan our 2027 schedule. We will be emailing the recording of this webinar. Give us a few days to put the email together and do some editing. So that'll probably be early, or I should say the end of next week-ish, around that time frame. So you'll get the recording for the webinar. Like Michael said, in the chat box is the CE credit. So go ahead and fill that link out. And then that'll notify Awaken to Sleep to send over your survey. Next month, our webinar is actually earlier in the month, so it's September 10th, and it's specifically going to be called Beyond the Bite Guard. So when TMJ pain isn't TMJ disorder, and avoiding those common diagnostic pitfalls in oral facial pain with Dr. Coburn. So that's September 10th. So we'd love to have you join us on that Thursday. And if you have any final questions, feel free to put those in the question and answer box. Otherwise, thank you again for joining us, and we'll see you again, hopefully in a few weeks on September 10th.
Cheers, Mike. Thank you both. Michael, thank you so much for sharing that valuable piece of information for us, or all that valuable information. And we're looking forward to seeing you in a couple of weeks.
That's awesome, man. I can't wait to see you guys. It's going to be a blast.
You won't see me. Frank will be there.
That's all right. You had a baby. You kind of have an excuse.
Yep. But we're looking forward to it. We actually just were making plans on that yesterday. So looking forward to seeing you. All right. You guys. Well, everyone have a wonderful evening. Again, Michael, thank you again for spending your evening with us and sharing your knowledge with everyone. We always love having you. So we'll get you on the schedule for next year.
Sounds great.
And thank you for all the attendees. Again, don't forget about your CE credits there. Keep me posted if you have any questions. If you need any assistance with your devices or anything, shoot me over an email. I'm happy to answer the questions or get you set up. But I hope everyone has a good evening, and we'll see you again in a couple of weeks.
Thank you, guys.
Thank you.
See you.
Thank you, Trish. You're the best. Bye.